Hello and welcome to this session. My name is Kjetil Heggelund. I'm a clinical psychologist and the head of an outpatient clinic in Northern Norway, working at the University Hospital of Northern Norway. A lot of our outpatient clinics have implemented CAPA, and I've been asked if I could come and share some of our experience with using the system. The presentation is called Getting It Right for Families Right Away Without Further Ado, how we use choice to get rid of waiting time in Northern Norway. And that will be the headline of everything I will be talking about today. How we went from having pretty high waiting times and the situation we have today where people pretty much can come in within a week. And how CAPA helped us get there. First, I have to show some mandatory slides. I have nothing to disclose. I have no bias. And I've been asked to have 3 learning objectives, which I could write down. And at the end of this session, I hope you will have an impression of our philosophy here, which is less focus on assessment. We find it there's not a lot of added value of going the extra miles with the assessment part. Patients and families usually seek help for specific things, and we try to get on helping early. I also point 2 there, early choice appointments make it easier to help. That is a shift in paradigm where before, when we got people in after 6 to 9 to 12 weeks, it was harder to help. It's as easy as that. If you get people in when they're ready to receive help, early, it's much easier to help them on their way. And also the point of choice, not just being a choice appointment, but we use choice as our primary care pretty much. Usually we end up with choice plus, choice plus plus, choice plus plus plus. If we see a way to help people early, we try and grab it and not stall it with changing therapists, unnecessary assessments, and so on. But we'll get into the details of that. First, I want to give you some context. I live in Norway. I have some slides here which will help you navigate where we're from. I've outlined it there. We live in the region of Norway called Troms, and here I put a circle around it. It's pretty far up north. It's a pretty beautiful place, but not a very populated place. I have some facts I will share with you. The area where our service is, it's populated with about 9,400 people. At the clinic I'm at now, we are 7 people working. And each year we get about 150 referrals. The area we cover is pretty big. It's about 4,000 square kilometers. And I've tried to put it into context. We're actually 2 outpatient clinics in this area, working pretty tight together. If we add them together, the total area we cover is about 9,200 square kilometers. And I've shown some examples there which you might recognize. For instance, London, 1,572 square kilometers. Some capitals and some countries also listed there, which are similar in size. So it's a pretty big area, but not densely populated. You have population centers, and usually we can get from, in our area, the longest drive would be about 2 hours. But mostly people come to our clinic to receive help from us. Here you have our staff. Currently we are 2 psychologists, me and another woman. We have 2 clinical social workers. We have 1 child care worker. We have 1 with masters in mental health. We have a health secretary, and we have a psychiatrist that is here 2 times a month with follow-ups for those who receive medical treatment. As you saw earlier there, we have 2 clinical social workers, and they compose our refugee team because we have centers for asylum seekers in our area, both for adults and for those young refugees which come here without any family. I guess we could call them single refugees, usually around the age of 15, 16, 17. They work with them for a long time. Together they have about 30 years of collected experience. The refugees come from a lot of countries, but nowadays we see a lot from Syria, Afghanistan, and recently Ukraine. Usually trauma cases, experience with war, loss of family, family being killed, family being kidnapped, sexual and physical abuse, both from their home country and when they escape. Some have also been victims of human trafficking. They offer help both individually and in groups. Recently, we had a group for Ukrainian mothers which had to leave their husbands back in Ukraine and are living in our area with their kids, but without their husband. And this is the topic of today. Maybe I'll try and make it bigger. Since 2018, we have had a dramatic drop in waiting times. Today, usually people come in, I would say within a week, maximum 10 days. But you see here, 2021, 2022, it's about 10 to 13 days. When it exceeds 10 days, it's usually because we inherit patients from other clinics, which means we inherit their waiting times. But this is how it's been for the last, we're in 2023 now, and last 3 years. And as it looks now, we have kind of found a way to make this, it's stable. It's not fragile. Of course, we're just 7 people here, so maybe the staff part is fragile, but our approach to how we want to help and how we do it has helped a great deal. And we'll get into some of the details. But first, this is a CAPA conference. So CAPA helped us shift the focus from what is state regulated, what is mandatory, what is required of our service, and moreover to the part which focuses on the value for the patient and what we want to be as a service. It took a couple of years to get there. We had some bullet points which we aimed at when we tried to we addressed both our organization and our philosophy and all, and it all started with CAPA. So the staff here, we agreed that our outpatient clinic, we want to make it a place I would take my own child to get help. We want to make sure everybody can come. Earlier, we had kind of a selection. The primary physician, the child service, send the referrals. We look over the referrals, and we did prioritize who would get access to our service. Sometimes it was a hit. Obviously, they needed help, and a lot of the times it was a miss. They could easily have been helped on a lower tier service. We didn't want to operate like that anymore. We wanted to make sure that everybody could come. We have a principle called as soon as possible, ASAP, and never more than 14 days. This means that if we get a referral from somewhere, we want to find time as soon as possible for them to come to us. In order to manage this, we had to drop the postal service to communicate with the patient and their families. We now pretty much only do it by phone because the postal service usually uses a lot of days. It just takes too long if we want to get in early. When they come to our clinic, everybody meets an experienced clinician at the choice appointment. We also want to make sure that we get out of the ditch we were in, where we felt that we had some ideas about what needed to be done to help this individual or this family, but we didn't have the time to do it properly. And we also wanted to focus less on assessment because our experience was that it added little value, but used a lot of time and postponed the part of the treatment part, which the patient and the family usually requests. So at first, we did what you in CAPA call the waiting list blitz. We removed everyone from waiting list, scheduled them with therapist. We also made sure that all new referrals didn't go on a waiting list. They were also prioritized so that we could meet people early, the new referrals. So this, of course, meant that everybody, for a period of time, I would estimate maybe a couple of months, worked a little bit more than usual. But everybody agreed on it. It was a joint decision. We wanted to change our ways and get to a better place. Yeah. Okay, as mentioned, just a little bit on the formalities of what patients can expect when they come to us. We pretty much always meet within 14 days of referral. Before they come, our staff makes sure that the basic assessment is completed before they come for the choice appointment. It's called DOBA. I'll have a slide that shows a little bit about it, but having some kind of decision-making tool, some knowledge before they come is very valuable, both to figure out what we're helping them with, also how which symptoms they show. And the basic assessments is usually not just the patient or the parents. Usually we get teachers also to chip in with their data. It's a big focus on that it's supposed to be a good experience for both the patient and the family. The format is usually about 1.5 hours, where at first we meet together. We allow the parents to use a couple of minutes just to say out loud why we're there together, so the patient can hear. Then we throw the parents out on the hallway and we talk to the patient alone. And that's usually the biggest part. When we have a pretty clear understanding of what the patient's experiencing, what they think they need, we will talk to the parents alone. Usually when people are alone, they can say something they don't say when we're all together. So we try and always give everybody a chance to express themselves without having taken into consideration the child or the parent. We will request understanding how the parents understand what's going on, what they think needs to be done. And then we all meet together eventually and reach a decision point. Yeah, and all of this is outlined at the very start of the session, or the choice appointment, so they know what to expect from their visit at our place. This is just a slide of the basic assessment. It's done online. They do it from their homes. Maybe a lot of you are familiar with it. You can choose a lot of informants. Usually we go for the patient, the parents, and a teacher. It can be anyone else. If someone else knows the child well and should be given the opportunity to complete it. We get, as you see on the left side, you have it's in Norwegian. So of course you might recognize some of them and some of them you may not. But there you have the most common mental illnesses, developmental disorders. You have each informant and how they assess the patient on each of these illnesses, diseases, conditions. And at the very end, you have the predictions made by the assessment. This is just one slide. This is the overview sheet. It's a lot of questions that goes into this. It takes about 45 minutes to fill out. It's a great way to get a feeling with what's going on. They also have a chance to write open-ended answers when they fill it out. And I go through it before the patient comes here. So we don't start from scratch. So we had a period where we used choice appointments in a little bit different. It was more a formality before the patient pathway was you're going to another therapist. But after a while, we decided this isn't working. It's not helping. So we tried to change it up a bit. And from our experience, this is some of the points that are pretty important for a successful use of choice appointments as a therapeutic mean and not just a formality. So who does choice is maybe the most important part. Of course, it should be an experienced therapist. They should be one who often succeeds with patients, good at communication. And of course, that is also one of the big the big factors that predict successful outcomes in general. So always try and kind of handpick who you want to do choice. There are other predictors of successful outcomes which we try and maximize here. And that's also why we end up with choice plus and choice plus plus. Early change usually predicts successful outcomes. We use FIT, feedback informed treatment, to measure the alliance and the outcome. So we can both make sure that the relationship between the patient and the therapist is doing well, and also that the patient is improving. Then we use the outcome measures of FIT. It's also a pretty good decision-making tool, because if you use the digital version, you get a graph. So if the patient scores very high on the outcome measures, usually the projections or the prognosis of treatment will be negative. So that will also add to the discussion with the patient and the parents. If this is a good thing to go ahead with treatment in the clinic. And we also try to agree upon common goals. Not always the easiest part. We try and use our experience, and they have their understanding. But together we try to find what would be the most efficient way of improving the situation they're in. We also focus on choosing wisely. This is an American movement. In Norway it's called kloke valg. It focuses on avoiding unnecessary tests, assessment, treatments, and procedures. We try to have it in the back of our head all the time. If basic assessment shows something, for example, you have elevated levels of anxiety, we don't try to not add another measure and another measure just to fine-tune everything and get the same results over and over. We just trust the basic assessment and move on to how can we improve the situation. We are trying to be very curious and active. We are the last tier service for children and adolescents with mental problems. There is not much past us, so we tried and be helpful early. We also try to be realistic. If our assessment is that we don't think this there will be much added value to going to our service, you could get the same results which go into a public health nurse, school nurse, social worker, child services, etc. We will say so. Usually those services are more accessible for the patients. As we remember earlier, we have a pretty vast area to cover. So it might be a long drive for a patient. So if our assessment is that you will get the same value from another service that is closer, we'll make all the arrangements if they agree, and that we will go that way. After they leave our office, we will call the nurse, we will get an appointment for the patients, and we will inform the patient. And usually it's not very hard once you reach a point where the waiting times are so low that you can tell the patient that, okay, if the other service doesn't work for you, you can come back to us. Just call us. It's much easier to get people to engage in another service than, for instance, if they had to wait 3 months and they finally come to us, and if our assessment is, nah, you should go to a public nurse. They may not be as collaborative about that. But our experience is that low waiting times, something happens, it's easier to get people to engage in other services if that is the same value as going to ours, and it's open-ended. So they can come back if they don't get the help they expected. Yeah, we try and be realistic and honest. If treatment is not necessary, we try and express it. If they still want to have someone to talk to, which some people might express, we go back to the nurse, for instance. There are other places where you can get that kind of service, and there is no added value to go into our service then. And as I mentioned with FIT, which can be a good decision tool with the basic assessment, sometimes there is a negative prognosis associated with the helping. We will show them the graph and have an honest talk about going to treatment, and that if you're doing really well, you're having it can be a negative prognosis with receiving help from us. We did there's been a study on our choice appointments, and I did an overview of characteristics with our patient data. And 47% of cases are closed within 3 contacts. And as you see, those are usually choice and choice plus. Choice plus and plus plus, I mean. It can be more than that with the choice therapist, but 47% of cases are usually closed in choice. Around 70% of cases are closed within 10 contacts. When we had an assessment about the choice appointment, how they experienced it, 98% of patients experienced being taken seriously and listened to. 95 pleased or very pleased with the choice appointment. 90% had the experience that the clinician knew how to help the family. Time is running, so we have to wrap this up. Things are going well here, but we try to keep improving. It's very important to keep the staff engaged, have an aim, move towards something, look for ways to improve. So the next on our list in our quality improvement program is to map the satisfaction of service with all users, not just the choice appointment, but after they're done at our service, we will map satisfaction. We already have the schemas ready, so we'll start with that pretty soon. And from that, we'll figure out which area do we want to focus on, which will add value to the patients seeking help at our service. Yeah, and this might all sound pretty fantastic, but in reality, there will always be outliers where things doesn't go as planned. Just be prepared for it. Every patient needs a custom fit. Even if it doesn't go well early, it can be repaired. Just, yeah. And don't aim for perfection. Get in early, get things done, focus on treatment. That wraps it up for my part. I'm done, almost exceeded my time. Thank you for listening. Have a good evening.